Today is an interactive session in chronic kidney disease, chronic cardiovascular disease, CKD, CVD. This is not a traditional presentation, just to interact together with some definitions. So the outline of my presentation, I'll start by some slides about why CKD, why we selected chronic kidney disease to be discussed today, and start this interactive sessions by this topic, and then what about the cascade of chronic kidney disease? Because when we know the cascade and we can interrupt the cascade, we can prevent the progression of chronic kidney disease or prevent chronic kidney disease, and this is the ultimate goal and our hope and the dream to benefit our patient. So I present some definition and classification of chronic kidney disease. This is the etiology in one or two slides, and then the main part of the presentation is to discuss some risk factors. Not all risk factors, but some important risk factors from my mind about chronic kidney disease. And then I'll end by a few slides for prevention. So the question why CKD, this is the first sector of presentation. You can expect that the complication of chronic kidney disease or coronary kidney failure only appear on the GFR is markedly reduced. But look at this data. The complications, you know, hyperparathyroidism, anemia, acidosis, hyperkalemia, hyperphosphatemia, all these are complications of chronic kidney disease. Look here, just modest reduction of GFR in these group of patients. There is some patients with hyperparathyroidism, anemia. So the modest reduction of GFR, you can see the complication of anemia and hyperparathyroidism as not exclusively for patients with marked reduction of GFR. It's clear? So you can expect that with severe reduction of GFR, you can find all these complications. But this is a very interesting paper showing that with modest reduction, you can see this complication just with GFR below 90 mg/min. The second point, the less the GFR and the more the reduction of estimated GFR, the higher the percentage of atherosclerosis. Here, the estimated GFR above 60, this is the percentage of atherosclerosis, and if GFR decreases below 30, you can find tremendous increase in the atherosclerotic plaque. So, chronic kidney disease means atherosclerosis, and it means cardiovascular, another important factor that may kill the patients which is atherosclerosis. And this shows the intermingling interactions between chronic kidney disease and the cardiovascular system. Another one, do you see this slide clear in the back? So, if you look here, what's this from the back? What's this? This is the camera. If you compare A versus B versus C versus D, what's the difference? There is a marked difference. Alpha here, it is relatively here normal in the beginning of chronic kidney disease stage 1 and 2, but look at stage 4 and 5 and find marked atherosclerosis. This is calcification in the vessel, and so you can expect the effect of this atherosclerosis in coronary perfusion and the impact on the heart status and the performance. It's clear? So chronic kidney disease increases the likelihood of atherosclerosis and the range of the coronary status. This is from comprehensive textbook nephrology. You can find here, this is tissue calcification, marked at the side of the shoulder. Another calcification about the lung. And this is very X-ray for the aorta and its branches. You can find major calcification in these systems. So what I want to convey from this slide is that many doctors consider active vitamin D and the calcium carbonate are the cornerstone of management of kidney disease or chronic kidney disease. But the lesson, if you give the patient active vitamin D liberally and the calcium carbonate liberally without monitoring calcium phosphorus, you will just gain this calcification that may kill the patient. To focus giving vitamin D and the calcium protein phosphate binders without monitoring calcium phosphorus, you just kill the patient and not modulate the hyperparathyroidism or metabolic bone disease. So please, whenever you write this drugs, you should monitor calcium, phosphorus, and PTH. What's your comment, Dr. Abani?
Carry on, because I've got a number of comments. So, okay, I think you better carry on, and then I'll do my comments later on.
Okay. So
I'll tell you when I want to comment, and I'm making notes here so that we can. I'll come back to all the points and all the slides you're talking about.
it's okay. So another important point that the infection here, this study, it's a recent study last month, showing that there is increasing the prevalence and incidence of different infections whenever the GFR decreases. So with progression of chronic kidney disease, there is increasing of pulmonary, gastrointestinal, genitourinary septicemia, and soft tissue. So chronic kidney disease is associated as well with increasing infections everywhere. And this is an important and interesting point. So the second point of the presentation, or second sector, is to discuss the issue of cascade. I extrapolated the chronic kidney disease cascade from Barry Brenner textbook of nephrology, and start with the susceptible person, because, as you know, there is a theory of double hit and triple hit theory for different issues for cancer and etc. Here, we start with susceptible person, and the susceptible person is defined as person with old age, with positive family history of chronic kidney disease, and low birth weight. If you look at these risk factors or susceptibility factors, you can see all of them are non-modifiable. So old age is non-modifiable, positive family, we cannot change our family, and low birth weight, low weight during birth are non-modifiable. So it just it makes the person susceptible for kidney damage. So when another risk factor like diabetes, hypertension, autoimmune disease, systemic infections, UTI, stones, urinary tract obstructions, and using drugs or herb remedies, of all these issues can directly initiate kidney damage, especially in a susceptible person. So knowing a susceptible person, this will be our target to get to exhaust myself in taking medicine, drugs, etc. So, and if I know these initiating factors and I tackle all of them, I can do something for these patients. So higher level of proteinuria, high systolic blood pressure, smoking, and poor glycemic control, all these factors are known as progression factors that cause worsening kidney damage and faster decline in kidney function after initiation of kidney damage. So what I want to convey from this slide is to concentrate on the susceptible group, because if you know the susceptible group, you can do your best for this person because they are more prone to chronic kidney disease. Initiating factors, if you succeed to cut all these initiating factors, you can do something for these patients. And at least if you work on progression factor, you will delay the progression of chronic kidney disease. But if you stay innocent until the end of kidney disease, your efforts will not be fruitful.
Can I just up to the point here?
Can I make a comment here just for a minute, Dr. Hussein? And then I'll come back to more specific problems. It seems as if we've discovered two types of chronic kidney disease in the last 10 years. If you ask me about chronic kidney disease 20 years ago, when Dr. Nagy was in Sheffield, or even 15 years ago when Dr. Muhammad was in Sheffield, and you ask me what are the most common causes of chronic kidney disease, I would say to all of them, and we used to teach our medical students, the most common cause of chronic kidney disease in the UK is number 1, chronic glomerulonephritis, number 2, hypertensive nephrosclerosis, number 3, diabetic nephropathy, number 4, chronic interstitial, and number 5, polycystic kidney disease. And I'm sure that's what you also used to teach your medical students until very recent. Until we discovered this EGFR calculation, and the MDRD formula and the new definition of CKD in 2002, and suddenly we're discovering that CKD affects 10% of the population, many of whom don't have chronic glomerulonephritis, don't have diabetic nephropathy, don't have polycystic disease, don't have chronic interstitial nephritis, and they're mainly old age-related CKD. So I think we need to take a step backwards as nephrologists and look at CKD in the community, which is what you started by talking about, and look at CKD in the referral hospital setting, which may be a very different type of early CKD at least. So now we talk about CKD, 10% of the population, old people with atherosclerosis and this. But as I said 20 years ago, they would never feature in our definition of chronic kidney disease, and we would be talking more about young people with glomerulonephritis, lupus, interstitial nephritis, or even polycystic kidney disease. I don't know if you have the same impression, Dr. Sobh and Dr. Hussein and all my colleagues, Tari and Maggie and Mohammed and so on. Suddenly we have two types of CKD, one type for the epidemiology and the population and the community and all these screening and prevention programs, and one type for the nephrology center where you have a completely different type of CKD. Any comments from you guys?
If you agree that we've got two types of kidney disease, progressive kidney diseases and non-progressive kidney disease, do you agree about this classification? Some of the kidney
That's
disease,
very important.
Yeah.
That's very, very important, because if you look at chronic glomerulonephritis, when somebody used to come, and they still come to the Sheffield Kidney Institute with a GFR of 40 at the age of 25 with a progressive glomerulonephritis, there's no doubt that they have progressive CKD and they end up on dialysis.
yeah.
But the guy who is 80-year-old in the community, who has the type of atherosclerosis Dr. Hussein showed us in some of his earlier slides, he would probably never come to dialysis because he's got a GFR of 60, he's 75, it might decline to 40 by the time he's 85, and then he will die, certainly, from cardiovascular disease, looking at his aorta and his vascular calcifications, and he will not be the type of patient we need to worry about preventing progression in his case. So again, the natural history would be very different in a polycystic with progressive cystic disease, in a progressive glomerulonephritis with significant proteinuria, in a woman with progressive reflux nephropathy and interstitial pyelonephritis. They're very, very different from these 10% of the population with community-based definition of CKD. And that's why you only see 0.1% ending up on dialysis. They're coming from probably the 1% with progressive CKD and not the 9% of community-based low GFR and microalbuminuria.
Even the 10% in the community, I have some comment in the next slides on the classification, and I'll make
Okay.
But Professor Sorkan,
Yeah, I agree. I cannot say this is CKD patient and I apply this for all category of patients. Of course, I have to put in my mind, as Dr. Meguid say, what is etiology? For example, chronic interstitial nephritis with a patient with creatinine less than 3, he may stay with you with a stable kidney function for years. But if you have other etiology causing this CKD, it can progress more than that with polycystic or with chronic interstitial nephritis. And also, you know, stage 3, you can classify it into stage 3A and B.
I'll discuss it later.
So, where are you regarding your patient in the cascade of CKD? and what is the etiology of this CKD, and also the age of the patient and associated other medical condition. This will make you take proper decision, putting plan for starting from psychological preparation of the patient and his family, and preparing him for treatment.
I remember what Mitch et al. Used to do in the late 70s when they tried to draw a line for the progression curve, and they saw it's just one line for all cases, and they tend up to be many lines for many etiologies, and even the same etiology you get many progression rate in different persons on the same etiology. And Jeremy White, remember Meguid, when he tried to break this line into different lines of progression, even on the same patient, and he tried to work up with things that affect the rate of progression in the same person, and ends up that there are some environmental factors that could affect the line, the rate of progression.
I have a fascinating slide about the trajectory of progression, so it will be here.
Another point regarding environmental condition, as Dr. Nadi
I
said.
have some slide about
I'm going to add another point.
yeah, okay.
Other than if you say patient with chronic pulmonary in Egypt and patient with chronic pulmonary in UK, it will be different, even if it is the same etiology. Even in Egypt, you see when summer is coming, we expect that most, if not all, our patients will show more increase in their creatinine. And when winter is coming, we will feel that our patient will show some decrease in their. Do you have this?
They feel a relief.
So CKD is very, it is not an even thing. It is very.
Two quick points before we move on. The study and the definition of progression that Maggie was referring to with the straight lines or the breakpoints, I suspect this paper from the 70s was on a population of hospital-based database of CKD. Again, not the type of CKD the NHANES or all these new epidemiology study are picking up. So these will be the same 5: glomerulonephritis, interstitial nephritis, hypertension, diabetes, and polycystic kidney disease. So there would be, for a better word, hospital-based CKD. And you're absolutely right, they have frequent breakpoint depending on variable factors, environment, blood pressure control, acute on chronic, and so on. And the other point that Dr. Mohammed was making regarding progression and non-progression, that is one thing that's missing in the current classification, is to be able to say CKD3 progressor or CKD3 non-progressor. So we use a P, as you know, in the NICE classification, but the P is for proteinuria, not for progression, and the P for proteinuria is a surrogate marker that this is a CKD3 at risk of progression or a CKD3 not progressive. But you're absolutely right, perhaps we need another P for progressors and non-progressors.
So if you agree with me that there are many factors that is fitting for all types of CKD, and there is specific factors and specific natural history for different causes of CKD. I think if we work on the initiating factors and the progressive factors, all these factors are fitting with any variety of chronic kidney disease. And there is some treatments, modalities, and some factors that is applied only for specific etiology. So there are some general aspects and some specialized aspects according to the etiology. So to go on the classification, I think we discussed some of the classification, but this is the primary classifications of people guidelines, stage 1, and I think all of you know that if the GFR above 90, this means the GFR is normal. Why we consider them as CKD? Because of the presence of proteinuria. Sorry, for resistant proteinuria or hematuria or abnormal ultrasound. Then stage 2, if there's estimated GFR decrease to between 90 and 60 for simplification, and this is 3, the initial 3 was between 30 and 60, and 4 between 15 and 29 or 30, and then below 15, this is the 5th stage. This is the original classification schema in 2002. This schema was very nice because it unified the definitions of chronic kidney disease all over the world between different nephrologists, so it unified the terminology, and it was the beginning of development. I think this slide summarizes the meta-analysis of relative risk factors. I won't just focus on some issues in this slide. The first point that I want to focus is the red arrow. You see the red arrow here? Red arrow in the slide. Red arrow refers to estimated GFR 60 milli per minute. So I want to say if the estimated GFR decreases below 60 milli per minute, all-cause mortality, cardiovascular mortality, development of end-stage kidney disease, development of acute kidney injury, or progression of chronic kidney, all these factors increases with decrease in GFR below 60. So keep in your mind 60 milli per minute estimated GFR as an independent risk factor, regardless the presence of proteinuria or absence of proteinuria. So this is the first statement I want to conduct on the slide. Estimated GFR below 60 is a bad line and denotes and protects all these complications. The second point related to the color in the slide. Do you see there are three colors in the slide? The blue one, which is this is the blue one, clear on the monitor, and this is a green area, and this is red. What is blue, green, and red in this slide? Blue denotes albumin creatinine ratio below 30 milligram per gram creatinine, and the green between 30 and 300, and the red one above 300. So the second statement I want to convey, the presence of albuminuria exceeding 30 milligram per gram creatinine is an index and a predictor for the mortality and the progression of chronic kidney disease and for susceptibility of acute kidney injury. Is it clear? So GFR below 60 or the presence of proteinuria by different degrees can predict all these complications. And this is just to simplify the issue, and this is to add to the complexity of classification, as Professor Nahas mentioned. Here, stage 3A and B, according to GFR, between 45 and 60, this is 3A, 30 to 44, this is 3B, and then if you look at this slide here, the green, this is the green column denoting albuminuria below 30 milligram per gram creatinine. You can consider this green column as person at risk and not CKD. So GFR above 60 without proteinuria, this you can consider it. This population are not complete, not having the chronic kidney disease, but they are at risk of CKD, especially in elderly patients with GFR above 60. So you don't make them in trouble and stress and anxiety that they have CKD. If the creatinine is normal, estimated GFR above 60, no proteinuria, renal ultrasound is normal, this is not a CKD person. This is a person at risk of CKD because he is in this green corner. So if there is, even if the GFR above 60 and there is microalbuminuria above 30, this increases the risk, even increasing tremendously with increasing albuminuria until the nephrotic range of proteinuria. If estimated GFR below 60 and there is no albuminuria, this is also increasing the risk with decreasing the GFR. So again, the same conclusion in the last slide. The GFR below 60 and the presence of proteinuria are very important factor to look at in classification and definition of chronic kidney disease. And this is a shorting slide. And because if you look, the population in this sector GFR above 60, albuminuria below 30 milligram per gram creatinine are 87%. What does it mean? This means that the pandemics, the person who are stating about pandemic of CKD in the population, they are 10%, they are really not 10%. Because the majority of 10%, 87% of these 10% are just in the stage of risk and not really CKD. So before saying and slamming
You see, that's a very important point.
yes,
Because you're just looking at all people with low GFR less than 90. That's all these 87% of the population are all people with GFR less than 90. And they don't really have a disease. They just have low GFR because they're old. So you're absolutely right. This 10% of the population is very, very misleading because, as you can see on this slide, 88% of these 10% don't have a disease. They just have low GFR. But then they should have microalbuminuria, Hussein, because if you call it CKD, then stage 1 and 2 is not just the low GFR, it's the low GFR plus microalbuminuria.
So some evidence of kidney damage.
Or evidence of kidney damage, correct, yeah.
but this is one of your slides from the master class that microalbuminuria may be a innocent finding, may just accompany the elderly persons, the hypertensive person, metabolic syndrome, smoking, infections, initis. So, you consider, this is one of the photos of master class, so you consider the microalbuminuria like urinary erythrocytation rate or CRP of the CKD. And another point you mentioned in the master class, whenever we say that the albumin creatinine ratio is high, we should look at the patient because this raised ratio may just reflect the aging process or wasting of the muscles. It is low creatinine rather than high albuminuria. So whenever we interpret albuminuria, we should put in our mind all these variations. Okay? This is a
And
model.
people don't do that enough. So many publications looking at the prevalence of CKD rely on urine albumin creatinine ratio. There is one just a month ago in The Lancet, one of the most prestigious journals, on the prevalence of CKD in China, and they conclude that around 10% again of the population has chronic kidney disease because around 9% of the population has microalbuminuria measured by a high albumin creatinine ratio, measured only once. So you don't really know how many of these people in rural China are malnourished, have low urine creatinine, therefore a high urine albumin creatinine ratio. You don't even know the definition of microalbuminuria in China because the cutoff of 30 to 300 or whatever the cutoff is, 2.5 to 30 milligram per millimole for females, or males 3.5 milligram per millimole of creatinine may be completely different in different populations where there is malnutrition, there is wasting, there is loss of muscle mass, or even different body composition, making the definition of albuminuria or microalbuminuria different from China compared to the United States or to the UK. So the paper at The Lancet showing that 10% of the Chinese population has CKD is a very good example of how we should be very careful when we look at some of these data of screening only once, screening relying on albumin creatinine ratio, so you don't measure albuminuria, you measure albuminuria and creatinuria. And it's the ratio between the two, so it could be any one of them, albumin going up or creatinine going down in the urine, causing a high albumin-creatinine ratio. And they come to the wrong conclusion that 10% of China population, which is, if China population is 1.6 billion, you can imagine how many millions imply to have chronic kidney disease in China, which is very misleading, and I'm very surprised it is published in the Lancet or even published at all.
I have a comment. Is one reading
Yes.
sufficient to say this is a sick patient? Of course, it should be repeated, and also we have to exclude condition. For example, if the patient is sick, is febrile, episode of uncontrolled diabetes, uncontrolled hypertension, he should be in his basal state, and this reading should be confirmed before I say this is CKD patient.
You're absolutely right. Read the paper in the Lancet. Number one, they only tested once.
Yeah.
Number two, the majority, 9% or thereabouts, relied on a high urine albumin creatinine ratio to define, and 70% of people with so-called CKD had uncontrolled hypertension. So I would call the paper in the Lancet, poor control of hypertension in China is a cause of albuminuria. No more, no less. And if you treat and control hypertension in China, you will no longer have CKD in China, which shows you that you have to be very careful. 70% of this 10% of the Chinese population, when they check their urine, they also check their blood pressure, and they found that 70% of those who had CKD had high blood pressure levels, either undiagnosed, untreated, or uncontrolled.
And I think this is very beneficial to be known. When we read any articles, we should apply the critical appraisal for this article. We shouldn't take this conclusion as an evidence. We should read the article in details and then find the pros and cons, what are the defects, what are the limitations of the article. But in the busy days, we can just read the conclusion and saying this is a fact, it's not fact. So this is
You're
very important.
right, and you know that's one of my main issues, is that one, the majority of nephrologists don't have time to read the article. Two, the majority of nephrologists don't have access to the articles. And three, the majority of nephrologists don't know how to read an article and interpret it. As a result, people outside the academic centers, not like in Mansoura University, Medical School, or Institute of Neurology and Nephrology, or the Sheffield Kidney Institute, people outside teaching centers, the majority of nephrologists don't have access. All they have access is news, abstracts, things on the internet, and they've never read the article that they quote. And that's very dangerous.
Continue. This is, as Professor Nagi mentioned, that when we want to evaluate the patients with chronic kidney disease, we should look at the progression of these patients. So we should not look at only one point of estimated GFR. We look at many points of follow-up. So if you look here in this slide, they look at non-linearity, and here non-progressiveness. But if you look to the line here, the line reflects decreasing of GFR. So if you look to the line is linear. So the non-linearity is approximate 0, and non-progressiveness is approximate 0 because this is linear and progressive. This may be a model of one of your patients. Another model, if you follow the patients for many reading, you can find the patient follow up like this curve. So non-linearity is 40%, and non-progressiveness is 66%. So this patient is completely different from this patient when you want to put a plan of management. And this is another patient. If you look to the non-linearity, this patient is 50%, and non-progressiveness approximately 100%, because this patient is not progressive. This patient has improving GFR. Another patient, you can find many trajectories of line of the progression you can draw from your follow-up. So, one of the important messages in managing our patient of chronic kidney disease is to look at their file, at their follow-up data, because as I remember, there is another study in Kidney International saying that when you want to decide the optimal time for the fistula creation, you should look at estimated GFR, the age of the patient, and the progression line of the patient. If you have a patient with 3 years creatinine 3.5 or 4 or 6, 3 years creatinine 6, while you are stressing him, you should do fistula now. So when you want to take the decision of fistula creation or starting dialysis, we should look at the progression as you mentioned. And this is a recent study published this month in the American Journal of Kidney Disease. These are the major causes of chronic kidney disease. Diabetes, especially type 2, is the leading cause, followed by hypertension, glomerulitis, and I think all of you know these factors or these causes. And this is by the new equation, CKD epidemiology equation, showing diabetes is the leading cause of chronic kidney disease. So this is the first part of the presentation, and the major part will be the risk factor for chronic kidney disease. Do you want to comment?
Can I make a comment, Dr. Hussein, about the American data implying that the majority of people with CKD are due to diabetic nephropathy? We have to be careful that these are not people with diabetes, type 2 diabetes, who are old and who have decreased GFR. It doesn't mean that they all have diabetic nephropathy.
Yes.
It's not because you have diabetes and you're 80-year-old and you have a low GFR that you have diabetic nephropathy. And again,
Okay.
we look at these type of data as on this slide, implying whatever 42% of all CKD have diabetes.
I
Maybe.
think the same with hypertension also.
Yeah.
Yes,
Yeah.
old people have a high prevalence of diabetes. Old people have a high prevalence of hypertension. Old people have low GFR. It doesn't make them have CKD, and that is the recurrent problem with the current epidemiology data and classification and definition of CKD by epidemiologists and not nephrologists.
Okay, this is the same as association and causation. How can I say the association and the causation? This is difficult. So I never say diabetic nephropathy, except if there is the classic presentation of diabetic nephropathy and there is the association of retinopathy. Do you see the slides now?
Yeah, I can see everything now, back to normal.
Okay, so the risk factor for CKD, I like the risk factor, I like to study risk factors. Why? Because I think the major job of physicians is to know the risk factors and to stratify the patients according to risk, low risk, moderate risk, or high risk. It's not just to prescribe medicine. And whenever we know the risk factors, we can treat them and to decrease the likelihood of the development of disease. So the definition of risk factor is something that increases the chance of getting a disease, and not necessarily the occurrence of disease. So whenever we say smoking is associated with lung cancer, this means that the person who smokes is more susceptible and prone to lung cancer than who doesn't smoke. But it's not necessarily that every person who smokes will develop lung cancer. So we should differentiate between risk factor and occurrence, because you can find some person, when you say that you are risky for the development of chronic kidney disease or any complication, the patient or the person can say to you, I have a relative who smokes for 30 years, 40 years, and he is very well, and another person who don't smoke at all and he has comorbidities. So the risk factor, again the definition, increases the chance of kidney disease and not necessarily the occurrence of the disease. So the risk factor for chronic kidney disease, I stratified them into some groups. The first group is...
Dr. Hussein, can I make a quick comment? I'm sorry to interrupt you again.
Okay, yes.
It's mainly for the people who watch this video later on. We should distinguish risk factors, which, as you very clearly said, imply a causation, that the factor causes or contributes to the disease, from risk markers, who tend to be associated with the disease, but not necessarily causing the disease. And again, there is confusion about that. Albuminuria is a good one. It's not clear to me that albuminuria causes kidney disease. Albuminuria, in my mind, is more a marker of kidney disease. But again, this could be discussed at another meeting or another conference.
Okay. So all of us know that obesity can lead to hyperfiltration in the beginning, and you can find here the GFR in the obese persons is more than the person without with normal body weight and no obesity. But I want to show this slide. This slide shows the relative risk of occurrence of chronic kidney disease. So the presence, the higher the body mass index above the normal, the higher the relative risk of occurrence of chronic kidney disease, and the persons with morbid obesity, that means body mass index above 40, have relative risk of 3.1. And here the slide will show the persons with low body mass index are at risk for chronic kidney disease. So the higher the body mass index and the lower the body mass index, and you can see this is a U-shaped curve. But what I want to stress on the definition of relative risk, what do you understand by the relative risk? What's meant by relative risk for person with morbid obesity? Relative risk for chronic kidney disease is 3. This means if you compare person with morbid obesity versus a control, suppose that you have 100 person here and 100 person here, so you can find CKD here 9 out of 100 and here 3 out of 100. This means that the development of chronic kidney disease is threefold. If you have another population, 1,000 here and 1,000 here, and it occurs, the event occurs in 5 here and 1 here, here 5 per 1,000, and here 1 per 1,000, you can find the relative risk is 5. So please look at the percentage before seeing this increasing 5-fold or 3-fold or 30-fold, because you can find this is a marginal if you even
comparison more
Yes.
than anything else.
So the relative risk means that comparison of the incidence in the affected group versus the control. Just divide the incidence here by incidence there. And this is, as you know, the metabolic syndrome is defined by 5 components, and if the person has 3 components out of 5, this is the patient with metabolic syndrome. The 5 components: weight, circumference exceeding some values, this 102 centimeter in males and 87 in females. So this is 82 in females. So this is the waist circumference. High blood pressure, high blood glucose, high cholesterol, low HDL. This is the 5 components of metabolic syndrome. So the higher the person, the higher the component the patient has, the higher the risk of chronic kidney disease, as you see here in this slide. This is a very nice study. Also, it included just 12 patients in metabolic syndrome and another 12 patients without metabolic syndrome. This is a study from Brigham and Women's Hospital. When they, in the urology department, the patients with renal cell carcinoma were subjected to radical nephrectomy, and then the pathologist studied the non-cancerous part of the specimen. So, and they have 11 patients with metabolic syndrome and other control, and they found that persons with metabolic syndrome have significant arteriosclerosis, as you see, and tubular atrophy and fibrosis. Another point that obesity is a cornerstone for development of end-stage kidney disease and for congestive heart failure, and constitute a link between cardio-renal syndromes. Another point in obesity, I am in hurry to just to finish the metabolic component rapidly and then to leave some time for comment. there is a terminology in nephrology, obesity-induced focal and segmental sclerosis. Focal means affection of less than 50% of glomerular. Segmental means affection of part of glomerulus by sclerotic area, as you see here. So you can have the pathology focal and segmental glomerulosclerosis for person who is obese. And the main dilemma you want to know, is it obesity related or idiopathic FSGS? Because if you diagnose obesity related segmental sclerosis, you just advise the patient to follow diet regimen to decrease body weight, and if you diagnose idiopathic FSGS, you treat him with immune suppressive medication. So this is an important question to be answered. The answer is not dependent on the immunofluorescence or the presence of segmental sclerosis by light microscopy. But the answer came from some clinical data. In obesity-induced glomerulosclerosis, you find nephrotic range proteinuria, but the albumin, serum albumin is preserved. So in obesity-induced glomerulosclerosis, you find albumin 3 something, but in idiopathic you find the albumin is very low. This is one point. Another point, if the pathologist is has in his mind that this diagnosis, he will measure the diameter of glomerulus that is not affected. In obesity-induced sclerosis, the glomerulus will be big, so it is glomerulomegaly. So glomerulomegaly is one indicator, and when they discovered for the first time obesity-induced glomerulosclerosis, they discovered that in autopsy specimen. They found obese person who died in accidents have some, the glomeruli are hypertrophied and they have glomerulomegaly. The most important part of the puzzle and the differential diagnosis of idiopathic from obesity-induced glomerulosclerosis is electron examination of the specimen. In the idiopathic form, you find fusion, universal fusion of four processes of the glomeruli, but in obesity-induced glomerulosclerosis, find patch effacement of four processes. This is what this how can we differentiate between both of them. All this is measured, and this is just showing that the effect of diet and weight reduction, because the only treatment nowadays for obesity is to decrease the calories and to follow the regime and then to exercise to just lose some weight. Because all the medicine working with obesity are obsolete now. So this is the first part of the risk factors. Do you want to comment, Professor Meguid?
No, again, it's interesting. The last slide you showed is very interesting, linking obesity to CKD and proteinuria. Because if you have CKD based on obesity and even microalbuminuria, and we've showed it as well, if you lose weight, then you lose CKD, which again shows you that this albuminuria, microalbuminuria, not perhaps overt proteinuria as on your slide, is not a good marker or definition of CKD. Because if you have chronic kidney disease and you lose weight and after 3 or 4 months you no longer have chronic kidney disease, that is not chronic kidney disease.
Yeah. But for simplicity, I omitted 2 slides about a very important question, which is obesity-induced glomerulosclerosis a benign or not benign condition? Actually, when they follow the patients after treating these patients with follow diet regimen and with ACE inhibitors for 6 months, they found everything is improving. But when they followed the patients for a longer period of time, they found that the 10-year survival of the kidney is just 50%. So it is, yes, it is more favorable than idiopathic glomerulosclerosis whenever you lose some weight, but it's not so benign because the 10-year survival of the kidney is just 50%.
Yeah, two distinctions here. I think that's a very important one. 2 distinctions. We should distinguish obesity and microalbuminuria, which is not a sign of chronic kidney disease. In obesity, it's a sign of chronic inflammation and is totally reversible. From obesity with focal segmental glomerulosclerosis and kidney lesions, and overt proteinuria, as you have on this slide, and that nobody would argue that overt proteinuria albuminuria and focal segmental glomerulosclerosis is not CKD. It's definitely CKD and can be quite progressive. So again, microalbuminuria is more the problem in definition of CKD than overt dipstick positive proteinuria. Nobody can argue that if you have 1 gram or 3 grams of proteinuria, you have chronic kidney disease. But I would argue if you have microalbuminuria with obesity, that's a sign of inflammation and not a sign of kidney damage. And all you need to do is lose weight, your inflammation goes away, and your albuminuria disappear.
There is a point, obesity is a complex problem. Usually you have obese, hypertensive, dyslipidemic, atherosclerotic. So you don't know what fraction of this constituent goes in this kidney disease. So it is a mixed problem.
Professor, there are 2 theories in this issue. The oldest theory is that obesity will lead to hypertension, obesity will lead to diabetes, both hypertension and diabetes will attack the kidney and lead to kidney disease. Yes, this is the one theory. But nowadays there is another theory called obesity in the central layer.
Yeah.
So obesity directly leads to chronic kidney disease, and obesity leads to this comorbidity. So there's a mix in the literature.
So to study this properly, you have to find obese patients who are not hypertensive, not diabetic, not dyslipidemic. So you can say obesity can cause so and so.
What you do is
And you have to define what you mean by CKD.
Yeah.
You can obesity and microalbuminuria. You can study obesity and impaired kidney function. You can study obesity and overt proteinuria, and these may be 3 completely different diseases.
I think we
But if you call them all CKD, you will never be able to understand anything.
not all obese patients have CKD. Not all obese patients have proteinuria or focal segmental changes in the glomerular. So just a fraction of the obese patients have this. So it's not related, probably not related to the obesity itself, but some factor in these obese patients, which is unknown, I think. You agree about that?
Maybe genetic.
Maybe genetic.
So not every obese will be hypertensive.
Yeah.
Also, this is a play of gene.
No, that's multifactorial.
It's the same with focal segmental glomerulosclerosis in black individuals.
Yeah.
Not all black people get FSGS, but if they have certain genes, like the myosin heavy chain or the apolipoprotein 1 gene, then they do get FSGS. If they don't have these genes, they don't get FSGS. So there may be genetic factors.
And more interestingly, that there is some data that persons who are black with a VOL gene, these patients better want to donate their kidneys, even they have normal kidney function. Because the development of all the susceptibility to end-stage kidney disease after donation in the black person with a whole gene phenotype, especially if they are homogeneous, the risk is high for the development of end-stage kidney disease. So smoking, another important risk factor, as you see, the more the cigarette smoked, the more the relative risk of CKD. And these are 2 papers that discuss the issue smoking is a kidney poison. The first one is the review article, and the second also discuss this issue. And just for the time being, the hurry, smoking can lead to microalbuminuria. Smoking is considered a risk factor for chronic kidney disease, increases the progression of chronic kidney disease, increases the progression of diabetic kidney disease. And I remember one of the review articles in Nephron, when the authors mentioned this issue, they said that smoking can lead to diabetes by increasing insulin resistance and then progress diabetic nephropathy from stage to higher stage. So increased diabetic adversely affect transplant outcome. And there are some funny data that if the donor is a smoker, the outcome of the graft is less if the donor is not a smoker. If the recipient smokes before transplantation, the outcome of the graft is worse. So affect everything.
Can I say something interesting about smoker and transplantation? Apparently the risk of cancer is much higher in smokers who are transplanted, who take an ACE inhibitors,
Yes.
comparing to smokers who are transplanted, who don't have an ACE inhibitors. So perhaps think about this when you treat your transplant patient with ACE inhibitors. If they are smokers, there are some evidence now that it increases the risk of cancer. I don't know how, but that's an interesting observation about smoking in transplant recipients.
It affects blood metabolism like cyclophosphamide. So if the patient is treated with cyclophosphamide orally, we advise him not to smoke, I think, because it stimulates the metabolism of the cyclophosphamide leading to drug cystitis, as you know. Because the damage of the glomerular bladder came from the metabolized cyclophosphamide. And Cambrian syndrome, because it enhances the expression of the genes in the alveolar system, so it is to this catastrophe. So this is how to stop smoking. It's not our job today, and this is the 5 A's: ask, assist, advise, assist, arrange regimen, and it needs the 1 hour for explanation. But the practical guideline for simple smoking cessation strategy is recommended to be an integral part of the renal patient treatment. So when you see the patient in the clinic and you ask them about smoking, as a smoker, advise him to stop smoking because of the kidney and not because of the heart or some. Because at this time the patient will be convinced because he is a renal patient. So this is the regarding smoking. I'll go to another risk factor, which is sedentary life. If the patient is not movable and not exercise at all, the risk of chronic kidney disease is too much. And there is some guidelines to enhance and to activate persons with CKD to have some exercise, at least 30 minutes walking, and the patient can take these 30 minutes in 3 shots, 10 minutes at least each time. And when we prescribe exercise for the patient, we should examine the patient, evaluate them, and prescribe the exercise that the patient can tolerate. If the patient...
Make a point about a lot of these associations. It's important to be very careful and read. I mean, I'm sure you have, but I'm talking to the audience in general, to make sure that these associations are independent associations based on multivariate analysis and also take into account other confounders. For instance, low exercise can be a cause of metabolic syndrome, obesity, insulin resistance, and then it can cause microalbuminuria. Low exercise can be due to the fact that people are poor, and poverty can be associated for many reasons. And poor people don't have time to go to the gym or jog or become member of sporting clubs and so on. So again, we have to be very careful for the audience in general. A lot of these associations are univariate, and sometimes when they do multivariate analysis, they don't include all the confounders. And it is easy to single out a single factor as a risk factor, when really it is only a manifestation of an underlying true risk factor.
But the importance of tackling these issues, it is a universal or generalized health lifestyle. So if we stop smoking, decrease calories, and even if they don't directly lead to chronic kidney disease, all these issues are indicated in persons with CKD. So,
but that is what we don't know, Hussein. We don't know that. We don't know if we exercise more, we will have less kidney disease. We don't know if we don't smoke, we will have less. We know of the association, but there's no evidence at all implying or showing that if we exercise more, we will have less kidney disease in 10 years' time.
Okay, I agree with you, but this is the health lifestyle. That's So,
I agree with you, but I'm talking in general terms for our young colleagues, not to assume that all these associations can be automatically preventable by preventing the associated risk.
Okay, I agree with you.
Yeah.
What this slide shows, if the persons are obese, smokers, and sedentary, the more the risk factors the patient has, the more the relative risk the patient has for chronic kidney disease.
Yeah.
So if the patient is obese and smokes and he is sedentary, the relative risk increases to 5.1.
And the more the risk factor of having high blood pressure,
Yes, the more the risk of another
which will give you albuminuria and will give you a definition of CKD.
Another important point that I want to stress upon, when we have a history from a patient with CKD, or have a history from a patient in the nephrology ward, we should ask the patient about the positive family history. We shouldn't neglect the family history of chronic kidney disease or nephritis, stones, etc. Because there is associations, and I know it's not an evidence causation, but if you look here, if there is positive family history, for the likelihood of risk of end-stage kidney disease increases in patients with different GFR and different proteinuria. So to ask the patient about positive family history, it is very crucial, and it's more. I stress on this issue even more in person who want to donate their kidneys for the brothers or something like that. Well, sometimes we omit this question and we don't concentrate on the family history. And when we proceed in preparation for transplantation, at the end we can find that there is a brother who died on dialysis, another sister died on dialysis, so we should put it in our mind. Family history is important. And the more interesting and the more funny, when I read this article, that the prevalence and risk factor for CKD in spouses and in wives and husbands, why I think the explanation is association of the common environment. If the husband eats a lot, like the wife, and there is some other confounding factors like diabetes and hypertension that is common in the community, and it can affect both husband and wife. So this is.
And also socio-demographic factors. Poor people or people living in poverty tend to marry people living in poverty, and for instance, people living in certain areas in Sheffield where there is more poverty than other areas which are more affluent, you find that the incidence and prevalence and even progression of CKD higher in areas of social deprivation. So again, it could be social factors, as you said, including environmental factors within these families. Yeah.
This is one of the slides that I want you to comment upon. Serum uric acid, the higher the uric acid, the higher the likelihood of development of chronic kidney disease and the higher likelihood of acute kidney injury. But I want to ask you about if you have hyperuricemia, do you recommend treatment for the sake of preventing the progression of chronic kidney disease or prevent CKD, or what's your advice and recommendation?
No, we don't. And I don't think this data is strong enough to recommend treatment. There is an association again between hyperuricemia, atherosclerosis, hypertension, cardiovascular disease, and reduced GFR. But we don't know that reducing serum uric acid will decrease CKD or will decrease prevention. And allopurinol and the drugs we have are not without side effects, so we don't know yet the risk-benefit ratio for intervention to reduce uric acid. We know the risk and the side effects of the drugs. The benefit is still doubtful, so it will need a randomized controlled trial, and only then we will recommend it to our patients.
Unless the patient is symptomatic.
Oh yes, unless the patient is symptomatic and he has gout, then we treat the gout. You know, absolutely right.
Or stones or manifestation of interstitial nephritis.
So if the symptoms are frank, like you mentioned, gout or stone,
I am treated.
but if the patient comes to you saying that I have ankle pain and some pains,
If you have uric acid high and no other explanation, and coming with recurrent joint pain, I will treat.
So do you have cut-off point for uric acid to treat, Dr. Meguid?
Sorry, I can't hear you very well.
Did you have cut-off point of uric acid above it, you prescribe albuterol. Suppose that the patient has
We don't treat asymptomatic hyperuricemia more or less regardless of the level. I think we measured them in milligram per milliliter, and our levels are between the normal level up to 400, I think, and 5, 6, 7, 800. We still don't treat unless the patient is symptomatic, off and on dialysis. So CKD 1 to 5, we don't treat unless they're symptomatic.
For me, if he is symptomatic, I will treat. If he is asymptomatic,
Yeah, that's what I'm saying. We don't treat asymptomatic, we only treat symptomatic.
Yeah, but if he is asymptomatic and have a very high uric acid, let us say more than 9, I will start thinking to give treatment. And of course, I know the risk of sensitivity or allergy to albuterol. I will give it cautiously. But if he is above 9, I will make mine to treat. Of course, if he is 10 or 11, sure, I will treat.
There are data linking uric acid with atherosclerosis and cardiovascular morbidity and mortality.
Yeah.
So this can be a rationale for treatment hyperuricemia even.
Yeah, again, you don't know that it is the cause. What you have with atherosclerosis, you have renal ischemia. With renal ischemia, you have increased hyperuricemia. You can even see it in preeclampsia. It doesn't mean that the uric acid is causing but I agree with you. If the patient is symptomatic, we do treat. Perhaps if they have very high levels, we don't see many with very high levels, but perhaps you could treat and see what happens.
in upper there is a sector about
Could I depend upon 24-hour clearance of uric acid? If it is more than 100, if it's more than 1,100 milligram per hour, if it is, I will treat in asymptomatic hyperuricemia.
This actually is supported in the up-to-date sector of treating asymptomatic hyperuricemia. If it exceeds 1,100 milligram per day, this is one of the indications. If it exceeds 10.5 in females or 13 in males, this is another indication. If the patient is prepared for chemotherapy, this is another indication. This up-to-date one. Again, the evidence.
It depends why you're treating, isn't it? I mean, you see a lot of kidney stone disease, and obviously you don't want untreated, very severe, high levels of hyperuricemia, because you may end up with hyperuricuria and more kidney stones. So it depends why you want to treat, and that's perhaps another factor in the decision making as to whether to treat or not to treat. As far as decline in GFR, I wouldn't treat at all. But if you're looking at kidney stones and other factors, then you may be justified to treat asymptomatic to prevent kidney stones.
Another risk factor is blood pressure. This is from Japanese population. If you look here, the white column reflects women and the black reflects men. So the higher the blood pressure the person has, the higher the likelihood of chronic kidney disease. Again, this is an association, as we mentioned, but this is the data.
But I don't think this is clear association.
How did they define chronic kidney disease in that study? Is it microalbuminuria?
No, it's major GFR, and yes, with albuminuria, yes. GFR.
Because it depends how they define CKD. If it is microalbuminuria, then of course all these people will have CKD.
Regarding hypertension, I have to go to the history. And history here will take 3 persons, me and Meguid and Nadia. You remember very long time ago, when we met together, I think in one of the editorial meetings, and you said to me, in Sheffield we have an observation that there is a relationship between hypertension and the progression of kidney disease. And you asked me if this could be a subject of an MD of one of our students. And at the time, I remember it was 20 or 20 years back.
More than 20.
More than 20. I said to you, Nadia Abadi can come. and make his
1989.
this issue.
Yeah.
And then he came
Yeah,
to Sheffield,
1989.
and Sheffield and examined and reviewed your archives, and he looked for blood pressure and its correlation with kidney disease and progression. You remember this?
I remember it very well. It was the Egyptian Society of Nephrology that you had in the Mansoura Neurology and Nephrology
Yeah.
Institute in 1989.
Yeah.
And Maggie then came to Sheffield in 1991. Did you come?
Yeah, that's right.
So this is good for history. Hypertension, I have a comment. Since actually, when you have a patient with creatinine and normal blood pressure and good hemoglobin, these two markers are very good markers that progression will be slow. In contrary, if you have a patient with creatinine, whatever it is, and you have anemia, you have uncontrolled blood pressure, these are indicators of progression. I think hypertension have a relation to progression. If you have a glomerular disease or a disease with no hypertension, this is good on. If you have glomerular disease or a renal disease with hypertension which is controllable, or hypertension which is poorly controllable, if you look to the matter like that, I think hypertension and anemia continue. This disease, how far it will be progressed?
I think the data are numerous for hypertension and progression of kidney disease. I have got to put proteinuria as well. If you put proteinuria and hypertension as two factors, then this is an awful lot of risk for
But by the way, Nagi, it is good for just scientific and moral issue. Nagi can give us a few lines or just a paragraph about your conclusion regarding your work in Sheffield.
Yeah,
Hypertension and the
my conclusion was, I think what was parallel to others' conclusion. Proteinuria is the first and most important predictor factor for progression. Proteinuria was the first,
but hypertension.
and the hypertension was the second.
Yeah.
And so their association is very, very bad for progression. So proteinuria is the first, and hypertension is the second. And actually, I compared two periods of time. Before using ACE inhibitors, the rate of progression was faster than after using ACE inhibitors. So ACE inhibitors make a differentiation between two eras of kidney progression rate. After ACE inhibitors, progression was a lot less than before using ACE inhibitors. Do you remember Meguid about that?
Yes, I do. But it's interesting, you know, because if you look at recent data from the United States on different periods before and after ACE inhibition, so in other words, before 1993 and after 1993, in diabetic nephropathy, comparing the two periods, there is much more end-stage renal disease and more progression of diabetic nephropathy after 1993 compared to before the use of ACE inhibition. But you're right, I remember the data from Sheffield which showed that proteinuria was the single most important risk for the progression of CKD, and it probably is. Yeah.
Another risk factor came from echocardiography. This is a relatively new risk factor. The presence of eccentric left hypertrophy in the echocardiogram is associated with faster decline of kidney function. Again, this is an association, but it links the heart with the kidney. So increased left atrial diameter and increased ejection fraction of the left ventricle were associated with faster renal function decline. The development of acute kidney injury, if you are a patient and he has in the past history acute kidney injury that necessitated hemodialysis, keep eye on this patient and focusing, and this patient, the treatment plan should focus on avoiding nephrotoxic drugs more than any patient else, because the development of AKI in the history that the dialysis put him in a high risk for chronic kidney disease and end-stage kidney disease. This is another story, the perception of chronic kidney disease risk factors among the physician. If you look here, this is among different physicians, you'll find the majority know the diabetes and hypertension, but less regarding the race and family history. So this is why we concentrate on the risk factors, because if we assume that whenever we know the risk factors and tackle these risk factors, we can improve the map and of lifestyle and the CKD, we can increase the education level of the general population and general physicians about the risk factors. Another and recent study came from the Australian Hypertension and the Absolute Risk Study Group, studied 322 GPs treating 4,900 patients, and they found that there is some treatment gap in this group and some prescription gap, and I think there is no time to clarify everything in this issue. But here, if you look, the persons who develop chronic kidney disease in this series of the patients, and they classify them into patient for whom antihypertensive medications were prescribed and the patient without prescription, and then they look at the patients with prescription, they found 46% of the patients are not achieving the target, and this is a treatment gap. And for the patient who don't receive the medications, 12% of them need the treatment and were not treated, so this is the prescribed gap, prescription gap. Again, chronic kidney disease, as WHO mentioned, it's a vital investment to prevent chronic kidney disease, and it's my hope and dream to prevent any disease, because this is a maturity of medicine, and I think the development of the country is gathered and evaluated according to the balance between preventive medicine and treating the disease. So prevention is better than cure, and this is a normal kidney. If you use, they are back to back and everything is nice, but if you look to this kidney, you'll find that the kidney has been shocked and destroyed by the disease that induces end-stage kidney disease, and we don't, as nephrologists, we don't like to see our kidneys by this picture, and this is the prevention of CKD should be considered in planning and implementation of national policies in the developed and developing world. And this is a nice observation, or this observation, it reflects the notion that Professor Soka mentioned that in weather, with a hot climate, there is increase of GFR or increase of creatinine. This came from Salvador. They noticed that there is a linear increasing of creatinine in men and women according to year working in this area of the world with hot climate. So the longer...
Can I comment on this paper, because that's absolutely very relevant to what Dr. Mohammed Sobh said. The same workers in this area who work higher up in the mountain, where the temperature is lower, don't have CKD. These people have only been measured once. So for all I know, all these people have is raised serum creatinine due to heat-induced dehydration. And when I reviewed one of these papers and rejected it, the authors could not clearly tell whether this was chronic kidney disease or just acute kidney injury in hard-working farmers in very high temperature who get dehydrated and just have high serum creatinine. If they stop work, they drink, their CKD will go away.
Another important that complement the issue is this is a paper that correlates the 24-hour urine per day with the decline of estimated GFR. So here, if the urine output is below 1 liter per day, this is the biggest or the highest decline in GFR. If the urine above 2 liters or above, even above 3 liters, the decline in GFR is so reduced. So if this is true, this means that persons with high urine output are less likely to develop chronic kidney disease. How can I have good urine output with drinking water? So good hydrations that allow us to have urine output at least 2 liters makes sense to prevent the chronic kidney disease. And this is
you can also look at it the other way around and say people with high urine output may have already underlying kidney damage and chronic interstitial damage and are not able to concentrate their urine carefully. So we have to be careful between polyuria and drinking, and I think the association cannot be automatically made unless we have a randomized controlled trial, different level of fluid intake, making the point. But to assume that urine volume exclusively equate to fluid intake and go to say that fluid intake for kidney disease prevention, it's 2 steps too far.
Yeah.
But, and the editorial mentioned that urine works well before the patient. I want to stress on this issue because there was a big question. As nephrologists, should we recommend for the patients to drink a lot of water or for the general population to drink water? So we should separate chronic kidney disease patients from general population. And this study was on general population. If we advise general population, the people in general population to drink between 2 liters and 3 liters per day, this will lead to hydration without side effects of this level of water intake. It will not affect the sodium level. But if the advice for patient with chronic kidney disease who cannot concentrate or dilute urine, the more they drink water, this will lead to hyponatremia, high blood pressure. So this is a misconception. So we should not be liberal with chronic kidney disease patients, and here the wise drinking, wise hydration between 2 and 3 liters per day drinking may be of sense.
But you see in England, the patient will ask you, what is your evidence? I don't want to drink 3 liters of water a day. I drink a liter and a half. I don't want to spend my day walking around with bottles of water and drink water unless you tell me what it will do. If it will prevent kidney stone disease, I will drink 3 liters a day. I'm not dehydrated in England because it's not that hot. So why should I drink 3 liters a day unless there is a good reason?
The answer will be there is no evidence, and this is the only one paper that discusses the issue, so we are waiting more evidence.
I think mentioning those humans with thirst, which help them to prevent dehydration and having kidney disease. So I would expect thirst.
Yeah.
I've got another example whereby people now are saying high urine osmolarity is a sign of dehydration. I say no, high urine osmolarity prevents me from being dehydrated.
Yeah.
Camels have very high urine osmolarity and they're not dehydrated, but they retain water very effectively. So that's why the urine osmolarity is high, but they're not dehydrated. So I think we have to be careful with all these semi-scientific publications that suddenly get a lot of publicity and the evidence is weak.
Yes, I agree with you, but if you look at the KDOQI and the KDOQI guidelines, the majority of these guidelines are based on weak evidence. So you can find just 15% of the guidelines are based on evidence, and the 85% are without good evidence. So, but if you find some interesting paper that makes sense, we can wait another evidence, or we can even test this study.
The point in real life, actually, a patient come and ask you, is it important that I drink excess water? This is a question usually which we face from our patient.
Yeah.
What I say to them, if the patient is a stool former or a stool patient, I say to him, you have to drink water sufficiently. He say to me, how much? I say to him, simply look to your urine. If your urine is yellow and concentrated, you are not drinking sufficiently. If your urine is not dark yellow, if it is light yellow, you are okay. So it is not a matter of 2 or 3 or 4 liters. You are still former. Please always keep your urine not dark. This is good point. But if another patient who is not a stone former, if he is not an end-stage or chronic kidney disease patient with polyuria, and ask me how much fluid I take, I will ask him your thirst. is your target.
So,
That is very, very reasonable. That is because a lot of patients believe that if they have CKD, even 1 or 2 or 3, they should drink 4 liters a day. And you're absolutely right, your thirst will tell you if you need to drink. If not, just drink what you feel like drinking.
but you can have some persons who are not eager to drink. They don't like to drink water. So,
Yes.
modest water drink is not harmful for general population. If the patient is not hypertensive and the patient drinks just 2 liters or something like that, it's better than drinking. There is no maintenance, proper maintenance of the filter. It's better to
It
drink
is,
the
the governors are, you have to change it regularly.
Another point of less evidence, I am happy by this discussion because this is a way of learning how to interpret the publication. Not everything later is gold, so we should read everything in details and we look at the limitation rather than reading the conclusion. So another work from the dietary acid reduction in fruits and vegetables or bicarb attenuated kidney injury in patient with moderately reduced GFR. The title in hypertensive nephropathy in individual with stage 1 and 2, and the title is interesting, and they just follow the albuminuria, and then the editorial said that the key to halting the progression of CKD might be in the produce market, not in the pharmacy. So it is another. This is regarding the obesity I mentioned. This is the cover of the Kidney International in March. This last month. If you look, this is the type of plant, the Sheashaa plant. This is in the Balkan area.
Balkan endemic.
And this can contaminate the wheat. If the person eat bread contaminated with this plant, these plants can lead to interstitial fibrosis, as you see here. And more importantly and more harm, it can work with DNA leading to adaptive cellular malignancy. This plant can come to us here in herbal remedies from China. So this is another point to take care of the environment and to take care of what we eat. And this is the established fibrosis and the interstitial disease in Balkan endemic nephropathy. So to summarize, sum up the presentation, we should, if we want to do something for the patients, we should concentrate in prevention. And if we discover magic drug or magic medicine or magic lifestyle to decrease the occurrence of CKD, this is a great success. If we want to work, we should work on we cannot work on susceptibility factor because it's non-modifiable. So if we work on the initiating factor or progression factor, this may help our patients to some extent. And I end with this statement: your life doesn't get better by chance, it gets better by change. And one of the changes from just treating the patient to prevent kidney disease. So worried with kidney disease, one of the important days that keep the attention of the population to the kidneys, how the kidney works, and how to get rid of the bad lifestyles from taking herbal remedies, medication, etc. And I thank you so much for your attention.
Thank you very much, Professor Hussein Sheashaa. This was a really very well put together, excellent presentation, and I've heard Hussein presenting now twice, if not more, and I'm always impressed by how up to date he is with his presentation, with his reading of the literature, and his analysis and comments. A lot of the presentations and slides you made refer to publications that are not even in press yet, but are online. And again, it's a credit to you how well read you are and how well informed you are. And I found this a very informative and good presentation. Thank you very much.
Thank you very much.
I also like the format of interaction with you and the audience and my colleagues and friends. And I think this format works very well. I don't think there is time, and I don't think we should go on to another presentation now. It will not be very productive. But I think we can talk for a few more minutes about your presentation if you want, about the format if you want, and about how to take it forward. But I found the system to work. I found the interaction very good, and the more time we have for interaction, I think the best for the two sides of the video conference. And your presentation highlights many points, the importance of detection of CKD, but we have to be careful how we detect it. We have to be careful about the definition of CKD. We have to be careful about all the publications we read, make sure they are not just reflecting associations, they reflect causality. And I think we should be careful about this idea of if we detect early CKD stage 1 and 2, we will prevent end-stage renal disease. We don't know whether detecting CKD 1 and 2 will make any difference. There's no studies. We don't even know the natural history of CKD 1 and 2, how many progress to ESRD, how many die, how many never progress. So to go and treat everybody with the GFR of 70 and microalbuminuria with ACE inhibitors may be a waste of time, a waste of money, and increased risk-benefit ratio. So I think there's still a lot to learn. And it's nice to see that in the audience we have senior colleagues who still remember what we discussed in 1989, and we've got younger colleagues who attended previous lectures and master classes like Mohammed and others who are keen to learn more. So I think we have to be careful and we have to be critical, and I think the new generation of nephrologists and the young nephrologists should be more critical, more thoughtful in their analysis of what they hear, what they read, and learn from people like Professor Hussein and his presentation.
So if you like, I want just to leave 5 minutes or something like that for my colleagues to ask you some questions. 5 minutes or maximum 10 minutes. So
No problem at all.
Any question for Professor Meguid?
I think one of the problems, can I raise another problem you have in Egypt, which is not the early detection of CKD, is the early referral of patients with advanced CKD. That is the real problem. You see a dialysis patient within a few days or a few weeks from starting dialysis, when they really should be referred to you at CKD stage 3, 3B, and not at stage 5. And I'm just wondering, what do you do in Egypt to improve early detection of CKD3, never mind CKD1 and 2?
I think it's the health service system here which is faulty. It's not the referring doctors, because many patients don't go to the health service unless very, very symptomatic. So they don't go early. And we discover these cases when they come with nearly needing dialysis very soon. So it's not the fault of the referring doctors, but it's the fault of the patients not going to the health service at the proper time. So I think we need more screening, more raising awareness of the population about symptoms, minor symptoms of kidney disease, and asking them to present earlier to their GPs. You're right, we meet many cases. I would think maybe half of the cases or 1/4 of the cases come in nearly needing dialysis or even late for dialysis. They come with uremic coma, uremic asthma, whatever. So you are right about that. We need to raise the awareness of the population on that.
And also raise the awareness for hypertension and diabetes, because this is where you find all your CKD patients.
Yeah, you're right. You're right. Some of the diabetic physicians should know about diabetic kidney disease and should screen the patients earlier than that.
If you allow me, I have just a question about the serum creatinine, because I saw your slide in the Mars Alam that denoting creatinine was a bomb in the. So if we don't use creatinine, what is the marker you recommend to use? Because
what I was referring to, well, two things. What I was referring to first is serum creatinine as a marker of progression in randomized clinical trials. If we do a randomized clinical trial to look at an intervention to slow the progression of CKD, we need to measure parameter of progression of CKD, and serum creatinine is not. Because I've experienced this, and Muhammad Subh would have experienced this in the 70s when we used to give patients low-protein diet. Low-protein diet lowers serum creatinine, and if you do a study on progression, a low-protein diet will lower serum creatinine and increase calculated GFR, because you eat less protein and you lose muscle and your metabolism of creatinine decrease. Nothing to do with true glomerular filtration rate. So if you want to study progression in a low protein diet study, you must measure glomerular filtration. I'm discovering the same with ACE inhibition. I'm discovering that there's a lot of publication that nobody refers to the effect, very strong effect of ACE inhibition on increasing tubular secretion of creatinine by the proximal tubule. And not a single study, except perhaps RAIN in a small group of patients, measured GFR in any study on the progression of CKD and ACE inhibition. Renal calculated GFR, IDNT calculated GFR, all these studies calculate GFR and don't measure GFR. And serum creatinine for the young people at the back can be affected by diet. If you measure your serum creatinine after a cooked meal full of meat, your serum creatinine can go up by 25%. Your serum creatinine is affected by your muscle mass, so if you lose weight and you lose muscle, your creatinine will go down. It doesn't mean that the GFR goes up. And GFR, filtration, number 3, and tubular secretion. And in CKD, we know that tubular secretion of creatinine can contribute to up to 50% of the total urine creatinine estimation. So there are 4 variables to assume that your intervention affects GFR without measuring GFR is wrong. And suddenly this fashion of equating calculated GFR with glomerular filtration rate ignores the fact that creatinine can be affected by diet, by metabolism, by muscle mass, and by tubular secretion. We forgot all that. So that's my point. My other point is that in CKD5, the MDRD equation is a waste of time because it's totally imprecise and inaccurate. So you cannot determine the rate of decline to ESRD based on a calculated GFR. If you want to calculate GFR in CKD, probably 4 and 5, you need to measure it. You cannot calculate it with the current equations because they overestimate GFR. Finally, the variation of the equation can be up to 30%. So if you start with a GFR and you show a reduction in progression by 20%, this could be the natural variation in creatinine measurements and in calculated derivation of GFR. And there's an interesting paper by Remuzzi in PLOS this month or last month making precisely that point, that serum creatinine and calculated GFR are not accurate enough to measure progression in a clinical trial situation, not in clinical practice.
So
in clinical, I don't need estimated GFR. I practiced nephrology for 35 years with serum creatinine very happily. And estimated GFR has made no difference in my clinical practice. I know when to dialyze a patient when his creatinine is 6, 7, 8, 9, or 10. I don't need an estimated GFR to tell me when to start dialysis.
Yeah. Good.
The clinical condition of the patient rather than the GFR that determine what I do there.
Yeah.
And serum creatinine tells you all you need to know.
Yeah.
Yeah.
In the hospital setting and in the clinic setting as nephrologists.
Yeah.
Epidemiologists need calculated GFR, but clinical nephrologists don't. Perhaps cardiologists need calculated GFR, so they know what level of GFR and they don't give too much radio contrast with their PCA and their intervention, but not clinical nephrologists.
Dr. Majid, I would like to ask about the use of ACE and or ARBs as a prevention of diabetic nephropathy in non-mortality patients.
Yeah, there are two studies. The Benedict study a few years ago with an ACE inhibitor and verapamil. And more recently, there's the roadmap study that used, I think the Benedict was with telmisartan, I may be wrong, but the roadmap study with olmesartan. And it basically delayed the onset of microalbuminuria, but the olmesartan roadmap study in, I think it was type 2 diabetic people, not diabetic kidney disease, showed a much increased cardiovascular risk. So using an angiotensin receptor blocker in people with type 2 diabetes to prevent microalbuminuria has a high potential risk associated with it, and an unknown benefit really, because why don't you wait for microalbuminuria to appear and then treat it? Or spend 10 years of giving olmesartan to somebody who may never get microalbuminuria, because then you have to treat everybody to prevent only 10% to get or 20% of getting microalbuminuria. The cost benefit is wrong, the risk benefit is wrong, and we know that when they get microalbuminuria, as long as you detect it, you can treat them very well. So be careful. I imagine these type of studies are pushed by the pharmaceutical industry so that you guys give olmesartan or telmisartan or whichever sartan to every diabetic patient on the planet, and then they become very rich.
And if you allow me, the roadmap trial using olmesartan, and if you read the article in details, you'll find that although the design is perfect, it is double-blind, placebo-randomized controlled trial, including a large number of patients, but if you read through the article, you'll find persons who received olmesartan, there is excess mortality because of coronary heart disease. So always look at the limitations of the study and the conclusions.
Good.